Good afternoon, friends. Welcome to this session, which is going to be very, very interesting. We are thankful to Sun Pharma for sponsoring this particular lunch symposium. And we're going to talk about something which is new, and that concept it can only be highlighted and to make us understand is Professor Rohit Sethi, whom we all know. He is the torchbearer of research from this country. He's made our country proud internationally. He's one of the best clinicians I have seen, and we know that he's a translational research person. He's developed the lab in Bangalore, Narayan Netherlands. I've seen that grow in last 2 decades in such a manner where things become like everybody wants to do research there. It's as such. And we know that people are powerful, and Rohit is more powerful. He's amongst the top 100 powerful researcher, scientist, clinician of this world for last few years. And today he's going to take us through the something which he's titled as a biological cleansing, and that is one of the concept he's trying to tell us for last 2-3 years. Rohit, all yours.
Thank you for those kind words, sir, and also for being such an inspiring figure from the time I was a postgraduate and the days I had come to AIMS. The talk today is something which has been very dear to me in the last few years, the concept of biological cleansing. I don't have anything directly linked to these presentations, even though I do receive some research grants for some of the studies from Sun Pharma, but nothing directly to the products or anything which I'm going to speak today. When you're looking at a concept of medicine and also the concept of prescribing any drops, we have moved on from this concept, which we started maybe 50 to 70 years back, that we have no idea about how it works on the biology, but it's like saying in the Rome once that Rome has spoken. This was a time when the church was all powerful and to change multiple things in the geopolitics there. So we have the same concept that I have spoken, I have no idea how it works, but the case is closed. But as we move on with our changes concepts of lifestyle and immunology, we are in the age of immune mimicry. The multiple zones of immune changes, what we see here, is completely different. And then we have all these challenges, what we see in our practice, the anterior segment, the high OSDIs, the phantom symptoms, what I call. These are very important today. This forms close to around 60% of your OPD post-surgery. If you really see for a few seconds, you've done a cataract surgeries, there are accomplished cataract surgeons, refractive surgeons in this, both in the audience and the chair here. And this bothers you. You do a beautiful cataract and then they come to you that their sensitivity to cold for years together. It never goes off. Foreign body sensation. I have sensitivity to air. Ma'am has done a silk surgery, smile surgery, and she has to deal with it, even though the patients are seeing 20/20. The machine skill is going to reach a stage of finest finesse. But what's going to bother us there is these things. So the phantom of pain, if you really want to get into understanding this, the phantoms I put here because you don't find the phantoms if the phantom finds you. Because the ghost who walks, we all have seen his cartoons, but it makes more sense in today's clinical practice. Because these are the things, again I repeat this, because for me, I keep telling to my residents, you learn the skill very well, but when you go out, what really bothers you is these patients. They are the ones who write bad reviews about you. They are the ones who feel that you're not a great surgeon. I know you, all of you can link to it. So Sharon and me, we published this very interesting work in Journal of Clinical Medicine. What are these kind of patients who have high level of discomforts, but you don't pick up anything on your slit lamps? As clinicians, we want everything to be seen. We want an OCT to be seen. We want the epithelium to be seen. We want a slit lamp to have some dots. We want to see everything. Only then we believe it exists. So remember, after this talk today, if you forget about everything else, remember there are phantoms in everything what you see in your patients. And what we did was we started looking deeper into the confocal microscopy of these patients. What we found was they had this very interesting microdeuromas. There's such interesting, like daffodils or you like gardens. You can create these kind of flowering patterns out there. And these are the ones who combine, who create a lot of challenges. And these are the ones which makes you unpredictable. These are the ones who end up in having multiple halos, glare, multiple things which you can't find an answer. So let's look at this picture, which you normally see in your today's practice. This patient has come to you for, say, refractive surgery, cataract surgery, it doesn't matter what. And you just see that. So what has been told to us is that epithelial maps are important because it tells you if there's a thinning in that some area, and that's what the work done by Dan Reinstein and many people, that is what helps you to decide whether you want to do a surgery or not. But I want to take you to a different dimension of what you don't see. Now, what are the phantoms you don't see is suddenly you open up, your same patient's confocal microscopy, the big phantom is your T lymphocytes here, and the big phantom is your antigen presenting cell or the dendritic cells. I know we all heard about them in our medicine schools. Antigen presenting cells bring the antigen to the T cells, and the T cells merge with them, and then they create cytokines. Then cytokines kill them. So now, for the first time, thanks to a lot of very detailed work by my colleagues here, you can see that an antigen presenting cell is trying to reach out to a T lymphocytes, and an antigen presenting cell here is trying to linking to it. I'm sorry, I can use this cursor if it works. This cursor doesn't work. So what happens is you have two things here. When they touch each other here, that's the first sign of contact that they are talking to each other and release. Ophthalmology is probably that's why I find it very exciting, because the first time ever you can actually see a biology in action, and if you have instruments, we can see them real life. And then what does it do? This is what makes you contact lens intolerant, it's what makes you irritant, this makes you patient have nociceptive factors, releases factors which kills your meibomian glands, and it creates genes which cause. The previous session was very wonderful. I was sitting in the back, Dr. Moitas and team, they were talking about PRK, the haze, the late onset haze. Most of them are driven by these. But what do we blame? We blame the machine, because we need something to be blamed. And the machines are never to be blamed, because the fault is always in your biology. And these are all pictures what you've seen about the whole different arm of what happens to the healing. But when you look at these factors, and one thing which is very interesting is you have a same set of patients with irregular epithelium, high inflammations, increased dry eye. And what do you use as cataract surgeons? The betadine, antimicrobials, and what are the pH? They're acidic pH. All three of them have very, very potent inflammatory component. And you do a cataract surgery, you are confident that these they are going to kill your bacteria. It's going to make safe for you. But what happens is, when you end up in having these things, these leads to inflammation. So the same thing happens to mitomycin. I'll come back to the betadine question again. Is mitomycin, when you use mitomycin in an inflamed eye versus mitomycin used in a non-inflamed eye, the action of mitomycin is completely different. In the interest of time, I'll skip a few slides. And we did this experiment. That means we created a mitomycin in a PRK eye or a cross-linked eye with a heavy inflammation. The mitomycin does the opposite. That means mitomycin is supposed to reduce the scarring. For example, the tumor necrosis factor here uh, which is out here and here. Ma'am, if you want, you can come, otherwise you'll have to strain your neck. Because I love the question she asks. I want her to be aware, because these questions helps us to go back and start finding answers. So what I'm trying to say is, because all of us are refractive surgeons sometimes. So what I feel is, mitomycin and betadine are like your children. You put them to a very good school with good people around and a good environment. The betadine and mitomycin will work like what your kid has to do, be good citizens. But you put the kid in a very environmentally unfriendly situation, what does the kid do? He becomes completely opposite. It forms the group which is the opposite. If the tumor necrosis factor and other things is supposed to create scar, the mitomycin with that increase it actually makes it more scar. And this was clinically seen in a paper published by Shadi Awad and team, that it exactly follows this trend. So what does betadine do? Exactly the same thing. Betadine in an inflamed eye completely behaves differently than in a non-inflamed eye. So what is important is, when you use betadine, it's important also, it's not moving the slides. Pardon? So it's important also to find out that the environment of what you use has to be mindfully thought of when you're doing it. For example, you are operating on a cataract and you feel that the betadine is used on this patient. You have to understand that this person may end up in having more dry eye. So if you go back, Dr. Shell is here, and you can go back and look at the patients who have a pre-op more of dryness and you use betadine, do they complain of more problems? Because suddenly you will have, out of 100 cataract patients, 10 will complain of terrible pain. And the second factor is the microscopic light. So what we did was, we made a set of our lab students under the microscopic light for 10 minutes. You take the immune profile, it changes. And the other eye, which was not where you're not put a microscopic light, it doesn't change. So it's a very important concept. It's working. I can change, you can take it out, I can manually do it then. Yeah, perfect. Thank you. And this is what this says, what we are trying to say, that it does change. And just skip. So what we have to do is, all the time, the hypothesis is always about, be very attentive about your drugs you use. Simple things can have a huge impact on your quality of outcome. The ion channels, this photograph is from New Zealand. It's such a beautiful picture which explains what is happening on your corneal epithelial cells. These are your epithelial cells. These are your sodium potassium pumps, and you need something to go in and out, because that's how it works. And this is exactly, and what happens is, imagine the sodium potassium pumps gets disrupted because of multiple things, whether it's your dry eye, microscopic light, betadine, paracaine, drugs, stress, vitamin D. And what happens actually is, there are these things which makes us very comfortable. If there are few of you are not comfortable to AC here, and if you're feeling that there's not, something is burning in my eyes, just remember that there are multiple pathways like this, and there is also multiple beautiful, the same sheeps going in and out, and this is your gates, what you saw in that picture. And what you see them is, if these gates are not healthy, which is very, very commonly seen in dry eye, what happens is, you start creating more pain. And that's one of the reasons, again go back to what Dr. Mohita's presentation was, that some people complain of pain, some people, you put a cold contact lens or an allergic dipped contact lens, they still complain of pain, because their TRPV1 is associated with lot of pain, and they don't have a TRPM8. TRPM8 is one which makes you feel good when you put cold water. And a lot of people, when you don't feel good, after you put cold water, that means you don't have enough of it. Alcon is coming out with a new drug which is working on to increase this by using some drops. That means what it does is it tries to increase this TRPM8, so that when it increases it, you feel sense of coolness. You feel like you're putting an ice on your eyes, so that the patient feels very good. So whole thing about ophthalmology today is all about how you make your patients feel comfortable and how you make your patient feel happy. And the happiness is not driven by 20/20 vision with your EDOF, it's about how you feel post surgery. Am I right, Shell, ma'am? So that means that our entire focus as you move on is not just your skill, it's about to understand all of them. So what we did was we did some nociceptive pain questionnaires, and I know a lot of us would agree that LASIK PRK is very good, no doubt about it. But lenticule surgeries create less amount of ion channel changes. So the person who complains that it hurts all the time at the end of the day, no, those are not the big complaints, but it's a challenge for your patients. Those things are not seen with lenticule surgeries. It's not the dry. If you compare between, I think there's no better person than Rupal ma'am here about comparing two things. I'm sure she would not have found, I have not found a difference of dry eye parameters between two. But what I have found a big difference is the way the nociceptive factors change, the feeling of good. You are comfortable in AC environment. A lot of patients tell me that I don't feel good when I sit in an AC car now after the surgery because it hurts. Because you feel, that's because, remember these channels, that means there is some alteration of this. That means you have to start looking at how do I improve this. That's something which will come at the end of my talk. And we have discussed about the significance of epithelium, discussed about how these ion channels, when they get disrupted, imagine all the beautiful surgeries you do. Say Abhay Vatsavada sir had done an EDOF lens, and he's not getting the EDOF benefit because you have created a change in the epithelium which offshoots that few amount of spherical aberrations, and you end up in negating the whole thing. That's because the ocular surface was completely not looked at, and you use more betadine. Not more betadine, it's just that betadine here has not worked the well it should be. And what happens if you do a refractive surgery here? This work was presented by Dr. Deepthi yesterday in one of the free papers, that if you don't take care of them at this stage, you do any PRKs or any surgeries, you end up in a very unhealthy environment. So we have published this work. This is a paper, what she said, looked at the tube necrosis factor, which is one of the major haze calming factors. And she found that these markers preoperatively itself can. So that means that when Daljit Singh sir used to talk to us that I've treated a -15 and I never had a haze, a lot of us were sitting there thinking we are smart and he was not right. In fact, in his generation, maybe 30 years back, in an environment he operated on with his patients, most of their patients had no computers, no TV and other stuff. So the TNF factors were this. So he was right. He could get away with -20 surgery, -20 on epithelium without creating any scarring. But today, say in Bangalore, Delhi, Bombay, any of these places, you treat a -0.5 and if your TNF alpha is here, without mitomycin, you may even get a haze. That's because your threshold is so high that you will, even if you touch the eye with the 0.5 diopters, you will get haze. That means the threshold of patients, the inflammatory milieu is the highest. So how do you work on this cascade? And that's what the whole concept of biological cleansing is. It's about, this is all academic work of looking at the markers. So it's all very important that we have to sum it down to something simple so that tomorrow, if you don't have all those academic related, research related markers, still you should be able to do it. We all have mammographies, we all can do a T-BUT, we all can do an OSDI. We know how to ask a question of contact lens intolerance, and most of the refractive cataract surgeons today have irregular epithelium. And if the score is, all of them are there, if they're more than 3 or 4, that means you are dealing with the high level of inflammation which can create all these changes. This happens even if you have one score for a dry eye patient, even if an epithelium is irregular or meibomian gland loss is more. When you do a betadine, you change your steroid regimen. Use cyclosporin in the initial part of it. Create so that your cataract patients don't end up in an irregular epithelium, which is the most common cause of challenge today of an unhappy patient. And this is a nice work done by our team, which talks about the scoring criteria. And what we interesting here is that in this study, you have correlated the scoring criteria to the biomarker work what we did. And it's very interesting study because you don't, even if you don't have these markers, you can use it in your clinic. What is the score? And the scores are exactly what I said: OSDI, meibomian glands, irregular epithelium. This, we still have not quantified what an irregular epithelium is, but it's more of a quantitative one, not a qualitative one at this point of time. And then this is what the biomarker kit is, which I've shown many times. Now I can proudly say in January this will be released. So anybody wants to buy or want to be part of this in any forms, you can get involved in this to the world actually. And we have all the markers which actually causes changes. Now it becomes much easy to predict and work on these factors. And this is all what I've just summarized, what I just said, how each one of those markers correlate to this. This for you to give you a sense of proof that whatever I'm saying has gone through certain amount of validation and other things. So what are the drugs which can use to validate it? Like I said, with no financial interest, I've used many other drugs also. But what is important is there is very little role, at least in big cities where I come from, when 98% of them are filled with all kinds of inflammation, including my eyes. I have a very high level of ICAMP1 and many other factors, which even though I don't rub my eyes, I don't have irritation. But what happens is we have to understand, just because it's like they say that, the tiger in the bush, or the tiger in the bush concept, where it's there, it's keeping quiet. It doesn't mean it's going to keep quiet for the rest of its life. It's just waiting for it to act. That means if I get any surgery or anything, even if I get a simple conjunctivitis, I will flare up like never seen before. So that's one of the reasons many of your conjunctivitis patients who come to you in your conjunctivitis season are not all the same. And you say, oh, this may be a different, it's not a virus which is different. What happens is it's your markers are different in them. For example, 99% of those conjunctivitis patients who come to you with terrible level of inflammation have this IL-17, ICAMP1, IL-6, which is so high. It's very classic signs of certain people who behave differently. It's like getting HIV and not all of them die with AIDS. It's because the immunocompromised status. It is a compromised status of your immune response. And that exactly happens when you use different drugs. So in today's context, it's important, this I've already spoken about. And what do we do if I meet 3 or more of the criterias? Like I said, that's one of the reasons I moved to Trehalose of any company you like. Even if it's like the company which done this, it's still okay, but move on to a different level of smart lubricants. Be very good at cyclosporin, and I use a 0.9% cyclosporin because that works faster and quicker to me. But when I'm seeing somebody with a lot of irregular epithelium, then I add lifitegrast. Lifitegrast and cyclosporin can be added together. They are 2 different pathways and it can be added together. Or I use an IPL if I have to do a cataract surgery. IPL reduces TNF-alphas and IL-17. So it's important that I try to do it. This is called biological cleansing. Like in that slide, you have to treat before you actually it becomes aggressive. And this is how Trehalose works. Trehalose is a natural component. It's available in all forms of plant kingdom. And so you can go back again, slides. And you can see all that I was speaking about, it works. We were looking at one project with Dr. Moita, and I was telling her that it is also like a cyclosporin, but it is a component which is natural. It's like curcumin. You eat curcumin or you eat resveratrol, you don't call it a drug. You call it it's a natural nutraceutical. Trehalose is a nutraceutical, and the curcumin resveratrol exactly works on this pathway, but we don't call it, we don't give the same respect as a steroid, because the word steroid is an immunomodulator. So I think this is what it works, and this is exactly the pathway in which it's working. And when you use combination of these, it works in a much better combination. So I've been always very big. We introduced restasis in 2006 with a lot of studies, but now moved on to 0.9, because this is what Dr. Moita also said in her talk previously, that it works faster. When you work faster, that means my biological cleansing is faster. For example, if I had to do a refractive surgery patient, I can't wait them for weeks. I can just start with a week and then do it. For cataract patients, I know that I'm going to use betadine microscopic light, and I'm putting a EDOF lens, which I'm very, very sensitive to decentration, not epithelial remodeling. I would start probably a week or 2 weeks would be better. People ask about the comparison between different drugs. And remember, this is a cyclosporin. It works intracellularly. Lifitegrast works between the handshake between an anterior presenting cell and LFA1 antagon, LFA1 receptors. And tacrolimus may be a little more stronger, 80 times stronger, but all of them can work together. That's the beauty of it. And that's why when you say cyclosporin, but one good thing about cyclosporin is it always works in every cell inside. Lifitegrast, the big challenge is not all of the cells, T cell, have a LFA1 receptor. So that if you don't have a receptor, the lifitegrast will never work. But cyclosporin, it doesn't care about a receptor. It just goes in. Remember that sheep's going in, and that's how this works. The resveratrol is a phenomenally strong drug in terms of oxidative stress. And these are the epithelial cells, and it reduces the epithelial stress. And I use this a lot in my refractive dry eye patients where there is a lot of turnover changes. And I use curcumin also, but combination of these two works very well. And it reduces inflammation. These are epithelial cells. Again, TNF alpha has a role in scarring, role in post-conjunctivitis, post-infection. It has a role because it's a remodeling proteins. It definitely has a role in that. And these are just a few slides which I'll skip. So these new drugs helps to bring the level of inflammation. It improves the ocular surface and tear film metrics, and this is what I call the biological cleansing. A few more slides about in keratoconus and post-refractive surgery. It's very important that because this is where the inflammation is in full vogue, and these are all the papers we've done about this thing. And this is the first paper of cyclosporin where it showed that it can improve the collagen synthesis. Anything which improves collagen synthesis for a refractive surgeon is a blessing, because this is where we start looking at it from a post-op status. And this is the few pathway papers which I have already shown, and I've already mentioned about trehalose and cyclosporin here, but this is where it is very important. Its tremendous role in refractive surgery is that it is able to change these pathways. All these pathways, what I've seen is written, the graphic is done by my lab students, PhD students. They draw it well because each of those PhD students work on one areas of work. That's MUD-D pathways, alpha SMAs, and multiple things. So it's so beautiful to see them draw these pictures. This is not from any textbooks. And this is one keratocyte, and what it happens in this. This is how beautiful, how vast our universe is in terms of one small keratocyte is like a dot. And what it does is when you have more inflammation, your collagen is degraded. You don't see the collagen. I put this TNF alpha multiple places, but with trehalose and cyclosporin, they start, boom, it comes up. And what is interesting is you have to be aware of this basal threshold when you're looking at complications. That's one I keep all of my patients for at least 3 to 6 months of this treatment, reduce the inflammation, and that's the biological cleansing in keratoconus. Because for me, if I don't, I end up in all these challenges. And that's one of the reasons my cross-linkage, even though I do 100% of my cross-linkage with lasers, I have very little patients who come to with very bad scar for which I need to move on to a PTK or a losartan based therapies. And these are just a few things which shows about the recovery of how the cells recovery after you bring in inflammation. This is a biomarker work. And what's interesting here is these are all patients not treated with cross-linking. You create an environment where you create them to increase more lysyl oxidase. The collagen will resynthesize. These are all just patients without cross-linking, just modulating their inflammatory status. We have now 200 and now this is biomarker 89 eyes, but we have close to 240 eyes, more than 3 years follow-up, and we keep them for around 6 months to 1 year. And why does this change? Why does the collagen changes? The answer still lies in the biology out here. Oops, yeah, just this is good. So I just showed you a picture which I will, after this picture I'll end my talk, is the picture here. Remember this picture of handshakes here? This is the handshake which every company tries to bring this kind of complicated structure, and we think that we'll never be able to see it live. But it's interesting that if you are a curious mind, all that which shown can be picked up in your own clinics. Oops. Remember this picture? Remember the handshakes here? This is your dendritic cell, this is a T lymphocytes. And what this secretes is what gets intracellularly treated by cyclosporin, and the lymphatic grass blocks them from meeting each other. It's like trying to block them so that they don't meet and they don't secrete. That's the whole. With this, I will end my talk. If there's any questions or anything, I'll be more than happy to answer.
It's a beautiful talk, as always, very mesmerizing. So say for example, for a general ophthalmologist who has not measured the tear film markers before, say, doing a PRK or a surface ablation, would it be safe to say that you can prophylactically consider using?
If you have those
cyclosporine?
five things, if you remember that irregular epithelium, T but less than
Yes.
5, high OSDI, you are a contact lens intolerant, and you are a nociceptive driven patient.
Correct.
Person. That means you feel that you have more nociception in terms of intolerant to AC water. Then it is always better to start them on a 2 weeks. If you are doing a cataract or a refractive, 1 week would do well, because, and if you're doing a lenticle procedures, 1 week would do well, because you don't disturb much of ion channels.
And how long should we consider using it?
3 months, 3 to 4 months. See, cyclosporin in the past used to start working after 6 to 8 weeks, so you need to around 4 to 6 months. Now you can work on it much faster. Lifitegrast, I keep it. Lifitegrast, what happens is it has a very good role in as a TGF post-scarring agent. Maybe I try to keep it during my PR case. But the cyclosporin is more for your ocular surface and ion channels. Lifitegrast role in ion channels is not very, very clearly know, but we think it may be because of these handshakes. So sometimes if you don't know what is happening, you can use both of them. Trehalose works very well because Trehalose stops the migration of these T cells into some extent. That's why this picture, which if you're not curious, you'll sometimes miss. You see a lot of them because these dendrite kind of thing are antigen presenting cells, and the single ones here, small ones, are your T lymphocytes.
Kit that is going to get available is going to have all these biomarkers.
Yes, ma'am. This when the kit is there, what will happen is you don't need to worry too much about it because you have all of them here, and it will tell you the quantification also. And the one which is necessary to this is your ICAM1 here, which is where the lifitegrast works. But the cyclosporin works on much grander, for example, MMP9, IL6, TNF alpha, IL17, and all that places it works. That's why sometimes, you don't know which is better. Sometimes one of these drugs work very well for one person, it may not work because the pathways are completely different.
Exactly. And does it also follow the same rule that if it's not indicated and then also you use it to not work?
Good thing about lifitegrast is if it doesn't work in 2 weeks, it's not going to work after that, 2 to 3 weeks, because it's more T cell. It works at this stage. But cyclosporin not so. You'll have to at least give them 6 weeks time to know.
And even after all that, if the patient is still symptomatic, what do you do?
The patient is symptomatic, then the factors may be multiple things. I mean, this is what we have just on the tip of the iceberg. There may be other hidden ones which we may not have been aware of it. But like I said, a lot of them have disrupted ion channels, which gets disrupted with your betadine a lot. Mitomycin disrupts it. In fact, I'm not against betadine. I will never be against betadine. What it can do is, I don't even think I can even talk about it. But we have to be aware when a person who is and has a different dry eye status, betadine works in a different way. So betadine has to be looked at it in a little more sensitive way in terms of how do you do a cleansing and how do you take care of it.
Wonderful talk as always.
Special thanks to you for doing so much work that really increases the horizon.
So, sir,
So
Madam
your
wanted-
groundbreaking work actually helps all of us in our clinical scenarios. Sir, at this moment, I would like to understand, for those clinicians like me who have no access for the markers, is there any clinical condition you will reserve use of lifitegrast over cyclosporin? And are there any typical clinical conditions you have observed where one molecule, any one works better than other?
We don't know at this point of time. Whatever I'm speaking is from a biological endpoint. Lifitegrast does have a stronger anti-scar properties, given a chance. But you always combine with Trehalose. Trehalose also has an anti-scar, so we don't know which one is actually doing the benefit. But cyclosporin, if I showed you the picture, all cells don't have the same kind of antenna to touch. These two cells cannot meet each other if they don't have an antenna. It's like falling in love here. If they have to be in love to meet each other with the same set of antenna and to meet, cyclosporin is not bothered about them meeting. It can go into any cell and change it. So that means it is an all-in-all phenomena. Lifitegrast needs them to meet. It just makes them to stop meeting them. That's from biological point of view. But which one works well? Because it depends on the pathways. Of course, we have to do a lot of studies. The companies, like all companies that are bringing out these products, also have to do studies, and so is lifitegrast. They have to. Lifitegrast works specifically on a molecule called ICAM1. That's one of the reasons. A lot of us don't have that ICAM1 molecule higher up in our dry eye patients. So then that means it may not have a reason for it to work. ICAM1 is the antenna of a antigen presenting cell. So that is the antenna what we pick up in this particular thing. And when you don't have that antenna, that means that drug will not work. It's like giving VEGF and there is no VEGF to work. What will VEGF do? Do nothing. So that is one of the reasons Zedra in US didn't work very well, because they had a lot of non-responders in it. So non-responders means there is no two cells which are trying
Pathway
to
is
meet
not
it.
active. Yeah.
And cyclosporin is an intracellular calcimodin and all the pathways. So it broad action of it, it works on multiple level of uh, pathways. So what that means that if one doesn't work, it moves to the other because it's intracellular in action.
Thank you so much, sir. And sir, when we say the word anti-scarring, does it mean the scar in formation, or it can work even after scar formation?
The scar in formation is driven by TGF pathways and TNF alphas. It is an inflammatory pathway. TGF beta pathway is a extracellular remodeling pathway. So that means you block the inflammation with cyclosporin or lifitegrast. The circle of life of how it cascades to the scar forming gets blocked. The scar, after you form scar, for it to resolve, you need to block it with TGF beta pathway, because that one I shown in one of my talk is that it creates, losartan creates collagenolisis on the scar to do it. To some extent, I'm seeing that happening in trehalose also, because that's why it's doing, but in much lesser level of this one. And the lifitegrast is working on both the pathways, so it's doing bit of both.
Thank you so much, and thank you for sharing your pulse. Recently I had one patient for refractive surgery, LASIK, and patient had very low Schirmers. We did biological cleansing as per your recommendation, and patient could go ahead with surgery later.
That's the beauty of it.
Thank you so
and
much.
What happens is, it's not the surgery which goes well, it's what happens after 3 months. You just do a patient without cleansing and without, your epithelial remodeling is completely different, and same thing works with cataract.
Thank you.
Dr. Jaya?
Sir, the lifitegrast that you used is all for units or the multi-dose vials also?
I have used only what Micro has given. I have not had experience with other ones, because I try to use whatever is the most standardized form of products. But like I said, there is no, I really tell both companies or any companies, there's no comparison between two, because both are completely different in action. It's like comparing a steroid with an anti-VEGF. Okay, there are two different pathways. You'll have to give them equal respect. There are two different pathways working here, and it will work there. For example, in my practice, a conjunctivitis patients who come with aggressive conjunctivitis, and these are the patients where you would probably need to use a lifitegrast there, because it will block the initial ICAM1 release. But a person after conjunctivitis and he is getting those scarring or those kind of things, cyclosporin works very well. So that means you have to think and match a lot. And these are the patients where you look at trehalose as a lubricant because it's working on it. So I have stopped looking at any lubricant as a dry eye lubricant. We don't have that kind of an evaporative, we don't have that kind of an aqueous deficient dry eye that, there's no tear film. That's a different ball game altogether. We need lubricants which can regenerate my collagen. We need lubricant which can regenerate my epithelium. We need lubricant which can have an action on an ion channels. We need lubricants which can help to maintain the stability of the ocular surface and nerve hemostasis. For biologically, if I get one, then that would be my best way to look at it. Losartan is not available commercially, but minute I started talking about it and we started making our own losartan, I see a lot of companies talking about losartan, but making losartan in a very refined form is not an easy task, irrespective of how big a company is. So we have to be very careful when people tomorrow come and give a losartan. It may just be something which doesn't work, and suddenly everybody says it doesn't work. So what we do is we take the API. API is active pharmacological ingredient. Am I right, Manoj? So that is what we take and we dilute it. The reason, if somebody asks, now there are a lot of strict regulations, so we can help you with some drops. But companies like Sun and all has to standardize it, and because that is a need of an hour actually. And we are trying to combine with different type of losartan, but it works wonderfully well, because scars which are very deep and which has happened many years back, it is trying to create it because it works on the TGF-beta pathway. It's not our invention. Steve Wilson from, I think, Bascom Palmer, one of these institute, was responsible for bringing it up. And but we started telling him that we can use different combination of drugs. Resveratrol by nature is also a very strong anti-scar drug, but I don't know how much of resveratrol we take in goes to the eye. But if you have a refined wine, tomorrow somebody might create drops from those wine and actually create a scar for me. I mean, people use coconut oil, so I mean, I'm just giving a thought.
And so, last one question. For the keratoconus stability that you showed, Trehalose, Trehalube along with the combined treatment. So that was along with the Trehalube. The other thing that you've used in that.
We use Trehalose 3%. Always when you use anything to Trehalose, all the research work is done with 3%. Companies are bringing lesser versions of it, doesn't work. That is one, and I use cyclosporin for 3 months. And
0.05,
0.09% now because it is faster acting. And the third thing is I keep them on, earlier I used to keep them on omega-3, but lately I realized that resveratrol does equally well because it reduces the oxidative stress on the cell, which is what causes your entire cascade of MMP9 collagenolases. This is what my protocol is, and cyclosporin I stop after 3 months. I keep them for a year of thing, and I call them every 6 months, and you will see that 60% of your patients have reduced in progression. If they don't reduce, you do any cross-linking. The cross-linking heals so well that after 3 months you will not even notice that you have a cornea surgery has been done. What is your worry after cross-linking? You used to have your scar, excessive, and I do 100% of my cases are laser-based cross-linking. So that means that my patients, I'm very worried about scarring, which I have reduced a lot. Thank you.
All good things need to end. So thank you, Professor Shetty, for sharing your tremendous knowledge with all of us. And thank you everyone for being such good audience. And thank you, Sun, for bringing this to us. A really good effort, and I hope you'll continue to do so. Thank you.